Okay, well, we're going to get started with our program. Today it's ICD-10 Transition Blind Spots. And Sharon Korzdorfer, she's the MPA RHIT Director for St. Luke's Health System. So we appreciate her coming. Sharon's holds a degree in Associates in Applied Science and Health Information Technology from Hutchinson Community College, Bachelor's in Biology from the University of Missouri-Columbia, and a Master's in Public Administration. Emphasis is not-for-profit in healthcare from the University of Missouri-Kansas City. She's currently employed by St. Luke's as the Director of Health Information Management and has worked for St. Luke's Health System as the HIM profession for the past 12 years. In her role, she is responsible for document imaging and document imaging audit, coding audit, clinical documentation improvement, cancer registry, release of information, and forms coordination across the health system. Sharon is also active in the KCHIMA chapter and served as president and past president in 2010, 2011. And the MCHIMA chapter, serving as the Director of Image Management from 2011 to July 2013. Welcome, Sharon. Thank you.
The one thing that I will say as well, thank you, Deb, this is a great venue. I always love those that are actually made it to the front. It's always like church and everybody's in the back. But we have a lot to talk about today. Please feel free to... Better? Can you hear me now? I've got the green light from the cameraman. Please feel free just to stop me if you do have questions while we're going through, and we will do more detailed in the panel. But one of the things that I wanted to get a feel of before we start is just a introduction and feeling of who's in the audience. And so I recognize a few faces, and so I know we have hospitals represented, I-10 program managers. Do we have any payers? You never see them showing up. Okay. Do we have any providers? Okay. Well, sometimes you do, but I have to be careful of what I say then if there are. And then how much on the technology side that are doing the testing, implementation, and programming? Good. How many on the hospital side? Good. And then the office side, physician office side. Perfect. Great. Okay. So it gives me a little bit of a reference. Well, the big piece today is don't let I-10 be part of your blind spot. And you don't have to let it be. We've had a bereave-in time period. Some folks took advantage. Some folks took breaths. Some folks turned away and thought it would be the ostrich in the sand and that it would go away. Government does shut down, so one never knows. So it has been a repeated comment and statement that it is not going away. October 1st, 2014 is the date. And as of this point in time, it's less than a year around. And so one of the big pieces that we need to focus on are the implications. And the group that we have here today, we're very readily aware of what ICD-10 is. But other areas that this is going to impact, it's very invisible. I was actually having a meeting yesterday, and we're putting together what we call knowledge nuggets for our providers and other ancillary staff, just to get a 4-minute little bits of information over the next year period of time with all the other competing resources that we have going on in projects. And the training manager, I found it interesting. Yeah, I keep hearing a lot about this ICD-10 thing, but all we hear is fear. And that's where we took our knowledge piece and turned it so that it wasn't the fear. It's not the, I'm going from 5 codes to 1 million. I am going to lose all sorts of efficiencies in my practice. We're not going to have any cash whatsoever. Now, can that happen? It can. You can't be fearful of it. You need to evaluate your process and attack it and move forward. But you definitely don't want to fear I-10, and don't let it be in your blind spot. So part of our challenge is coming from senior executives, other supporters that need to continue to make this a focus. And the reason that that's important is because, as in every part of our industry, this is not the only project. This is not the only high priority project, and it could get lost. Or they think that you have at the beginning of your Gantt chart and enough resources, but they slowly get trickled and pulled away to other resources. So you need to make sure that this is obviously something that you have backing from an influence perspective. But then we also need to know that there are pitfalls that you can run into. And so I'm hoping today, this is a very high level, this isn't detailed. I'm hoping that you gain one or two pieces of nugget knowledge of what to be looking at and what to be focusing on. But I could stand up here all day and we could talk about the I-10 project plan. I know on ours, and we did our gap analysis back in 2010, we have 786 line items that were at the high level, and then each one of them had individual details. So I could be here for a very long time, so I apologize if it's too high level for you. We can always go into details at the speaker level as well. Are the language of healthcare, and they're going to impact everything. The way that most HIM professionals look at codes is that we feel that we can take a claim and be able to evaluate what that patient was in for, why they were here, what their background is, what their problems may have been, what occurred at the office or the hospital, and what their future may even bring as a beneficiary for a payment perspective. Everything is related to the code, and that's difficult, and that's why we're changing to ICD-10, is because I-9 doesn't serve that purpose. We have one code for a coronary artery bypass, and there's a lot more going on with a coronary artery bypass than just one simple code. And so you have all of the different areas. You've got our HIM, IT, clinical care, payers, finance, and I-10s touching all of those. But within each of these different areas, and there's some overlap in several of the sections. What about your charge master? What about your DRG shifts? What about your evaluation for all of your rebilling and initial billing? Those are the things that we need to make sure that they're interconnecting and that the code really does end up being the language of ICD-10 and how we're going to survive. So wanted to just give you a brief look at the agenda. We're going to look at timelines. We're going to go over vendors and clearinghouse, testing. What are folks doing internally? How are you managing external testing? Education, your staffing resources. We'll talk about CACs just a little bit. Dual coding versus double coding. Financial analysis, contracting, and denials. So one of the pieces that I often take a look at is the timeline. So we've got, I'm a walker, I get bored up there. We've got the timeline. I hope that wherever you're at in your organization that you've told someone that I-10 is happening or that they know that I-10 is happening. I think we're well beyond number one. Appoint an interdisciplinary steering committee. Depending on your organization, you have identified folks that are going to create your steering committee or be appointed to the steering committee. There are many areas that thought, we can do this internally. We don't need a program manager. Someone else can do this as a part of their job. And then they call Linda and they say, Linda, we need help. We need a program manager. We need someone to really focus on this process. So depending on the size of your organization, you may have hopefully already not only developed your steering committee, but identified what that plan is with your strategy, but determining functional area opportunities and gaps. So there are some institutions that have done gap analysis many years ago, and then they did nothing with it. So there's no point in doing a gap analysis if you're not going to evaluate what those opportunities are and then actually develop workflow and work plans and groups that are actually going to change. ICD-10, don't fear it. It's one of those things that this is the one opportunity that we have that's large enough that if things aren't working well in your rev cycle process or in your evaluation of finance, this is how you can change it. You can blame it on ICD-10. Well, we have to change this because of ICD-10. So if anything, embrace the opportunities that you have in your functional areas. There should be, with your steering committee, interdisciplinary project management, partners with vendors. So this is very high level and encapsulating. Is it a vendor that's helping you with testing? Is it a vendor that's helping you with staffing for coding education, staffing resources? We'll go into some of those vendor sections specifically. Implementing plan in place. So with the payers, depending on who your largest payer population is, those are the folks that you need to make sure that you are in sync with. And many, Medicare is our payer, and will be even more so in another year based on the population of patients that continue to expand into Medicare. They, other than the WHEATY end-to-end testing program, there's not a whole lot of pure testing with that payer. So we need to make sure that our processes are set in place. Provide detailed training. To whom? Did you get one area set very identified and structured, but completely forgot about another area? And then simulating management change. Healthcare, we're continuously changing. If you can't embrace and make sure that you've got an encouraging change management program moving forward, that could be you may have done everything correctly, but if ICD-10 isn't pulled into your change management program, that could set you up for complete failure. And then at some point in time, we'll be a success and do some exciting celebration. So we've got vendors and clearinghouses. And I will tell you that when Dr. Waldron comes in, you can ask all the IT questions to him. I am an HIM background. Vendors and clearinghouses. From that perspective, that is why we rely, and when we go back and we see this picture, every single one of these areas has to work together in order for this to be successful. And so in order for St. Luke's to be successful, I rely heavily on our program manager of RevCycle, and she works through all of the different processes and gaps that we have identified. And we had a plan. It was a great plan. And then our clearinghouse decided to throw in a little bit of a loop. Yeah, we're not going to be able to do that full end-to-end testing with you until September 2014. So we have 1 month prior, and this is a fairly large clearinghouse. I won't throw out names. But there are those types of issues that you could have a plan put in place. But if that plan is diverted or set back, you're reliant on the clearinghouse, you're reliant on the payers, you're reliant upon your vendors to coordinate with the plan that you've put in place. So the big piece is around asking each of the vendors and their clearinghouses, what system changes do you have in place? What's your timeline? And evaluating the testing so that you can coordinate. There's no point in putting it on your testing plan if they're not going to be ready and if they're not going to have any availability to provide data back or feedback back. And then how long is it going to take? You may have on your Gantt chart that it's going to be a 2-week integrated testing scenario, and they're only going to be available the last day or two of that integrated testing. Well, you've now wasted all of your resources. So it's really that integration, not only between your interfaces from an internal perspective, and we'll talk about testing here in just a second, but also across the entire enterprise. From a system integration from different vendors, there are many that automatically are doing this. I'm typically it's just part of one of your patches or upgrades or moving from one version to a next. We have not typically seen that this is an additional charge. But there are some smaller softwares that are having challenges with converting and are a little bit behind the 8 ball. But converting internal built systems and reports. We see this less and less in the larger institutions. They're obviously not having a whole lot of homegrown data systems, but it does, don't forget about your Crystal reports and your SQL reports and things that you may have had from a canned system, but then internally had your SQL or Crystal report writers creating information. And again, technology can do anything. But if it's not put into place of how you want your workflow or how you want your endpoint to look at your organization, I'm Sally Jones. On Tuesday morning, I always run this report, and it's all still on I-9 based, and I can't do the rest of my role. And so the examples that you want to make sure is that if you're in the midst of an application and you're reviewing through all of your processes, what are your control variables? What do you know that is not going to change that you can evaluate with your vendors in your clearinghouse? So within testing, I talked a little bit about the clearinghouse, but I just want to reemphasize it and reach out to them and make sure that everyone is on the same page of your timeline and that they feel that they can be able to move forward. And for the most part, we've talked with many institutions across the United States, and we've not seen that as a large of an issue because we were quite surprised when we heard the announcement. But it was a blanket announcement they sent out to all of their providers that they provide services to. So we're all in the same boat, and now we're just trying to work together to evaluate. So testing can take up to 19 months, and we're past the 12-month mark. So where does that put us? It can put you a little bit behind, but depending on your resources and your testing scenarios, and that's the big piece. Depending on your organization and your facility, how complex are your workflows? So in a hospital and a health system organization, we have psych, rehab, SNFs, long-term cares, home health, normal acute care, ER. We need to run through all of those scenarios. Do we have an uninterrupted 3-day rehab stay? Do we have a rebill that needs to occur in between that time period? We need to be able to make sure that the process and the workflow is only going to be as good as what we've tested. And if we don't, we'll talk what happens on the financial side if we don't. So coordinating that internal testing and transition plan with your product implementation piece, along with the system upgrades and replacements. So within your testing plan, then you need to know where all of your software applications are doing the upgrades, and does that prevent, or are you gonna freeze, or are you gonna hold, and you're not gonna be able to do testing and implementation. That's where it does get very complex. How many software applications do you guys think in each of your organizations? Some may have 5, some may have over 150 different applications that you need to coordinate all of those systems. And from a training and a testing, from an implementation and testing perspective, that is where the challenge comes from, make sure that they all do actually work together. We talked a little bit about costs, but we've not seen that as big of an issue. And then when implementing any of the upgrades or the new systems, have you already completed part of your testing, but it was prior to an upgrade or a patch? And so now you need to remember to go back and make sure that there's not been any changes based on, we read the release notes, we think we know what's going to happen, but then you put it in test and production and something may different occur. And then how your products are going to be able to accommodate both 9 and 10. We know very well that there are non-HIPAA reliant organizations such as work comps and others. They don't have to have the claim in 10. So how are you going to reproduce? Or the RAC, they can go back 3 years and you want to do a rebill. So can you do everything in 9 just as you can in 10? And most of the systems are going to be able to. When we went to MSDRGs in 2007, we had one version of pre-MSDRGs and we had a version after. But those are the things that we need to be looking at. End-to-end testing, I'm not going to spend a whole lot on other than knowing that you have an opportunity to participate in the industry best wide practice for end-to-end testing, and the 3rd phase of that pilot ended just last month. There are great checklists and great workflow processes, but it is actually going through the entire end-to-end testing that is important. And that is, to be very honest, what we are most challenged with at our organization with our clearinghouse institution blip that they have given us. Education and training. So one of the things that we know, and again, depending on how big your organization is around education and training. So from an HIM department perspective, we've been training our coding staff, and not only with I-10, but the knowledge capture piece of ICD-10 is much more around anatomy and physiology, and coders that have been coding for 20 and 25 years, they have codes memorized off the top of their head, and they're not always 100% sure what's going on in that procedure, but I know that it's a bypass, and I know what code that I need to put for my bypass. So those are the challenges that we had to hit first, and I think most HIM departments have felt pretty secure in evaluating, getting competency training for anatomy and physiology, and training their coding staff. And then I hear, we were talking with our training manager yesterday, well, the fear is that they have to know I-10 codes. Like, they don't know I-9 codes. Why would they need to know I-10 codes? We don't want them to know codes. We don't want physicians to be memorizing, although our cardiologists already do know that I-10 is hypertension, so they think that they know some I-10 coding. But there are several different aspects that you can take towards training. And so you know that you have different levels. You need to be able to evaluate systematically groups and not just, Luke's has over 10,000 employees. Do all 10,000 need to be educated? No, but over 6,500 do. And so we've grouped each of these folks based on the level of what their group, and typically you can take your security, Active Directory roles that you've evaluated, what software applications that they have access to and that they can document as to what type of training they're going to have. But then you need to evaluate, well, how do we get this training done? We're transitioning from one EMR to another one during this period of time. I didn't say we were smart all the time, but we're very ambitious. And so Q1 2014, many of our resources are around the education of moving to this new application. Now, one of the things that we've done is we could have cried and whined and thought, what are we going to do? I-10 is in the back of our minds again. Well, what we decided to do was we evaluated what does that EMR bring to us that we don't have today, and how are we going to already start inserting some education while they're receiving the education for that EMR, because that's required. So I thought of it as a fantastic, I have these folks in and they are mandated to be in front of me. This is an opportunity for me to actually be able to insert some additional education. And so as you move to different applications, what are the advantages? Do you have templates that you can go ahead and coordinate and actually create so that it's I-10 compliant and not dealing with something after the fact? Do you have opportunities of IMO in the background for your problem list so that it's viewing an I-10 code versus an I-9 code? Do you have capabilities of running data and evaluating who are your top performing providers from a volume perspective as well as from a dollar perspective, and making sure that you hit those folks? Outside of providers, I'm a nurse, I don't do anything with coding today, I don't need to know anything about ICD-10. Yeah, you do, because you're going to have a very grumpy provider, and they're not going to know why they're being asked. You may have a ClinDoc program concurrently. I hope you do if you're in a hospital setting. You may have coding staff asking folks questions after the fact. Everyone at least being aware. You need to at least have an awareness level for folks that may not think that they have anything to do with coding and billing, but if you're providing care and you're documenting, you have something to do with ICD-10. And then what type of training do they need? Now we know that some providers will need more specific training based on their specialty. Surgery is going to be probably one of the biggest challenges. Surgeons are still going to bill for themselves professionally via CPT, and the hospitals are going to need much more information and specificity than what we've currently asked them for, and they're going to say, why do you keep bugging me? If they understand, and it does get even more challenged. Are they employed? Makes it easier. Doesn't make it easy, makes it easier. They're contracted. Depends on what the contract says. Could make it much easier for you. It could make it much more difficult. And if on, not the provider side, but on your nursing and other case management, revenue cycle, if you have any temporary or agency staff, what if they're coming in? Have they been trained? What level are they at? Those are the types of evaluations that we're going to take a look at from an education and training perspective. But who's doing it? We have lots of folks in our organization who have become AHIMA I-10 certified. And it's just like any other bell curve shape. We've got folks who know it a little okay. We've got some folks that I feel pretty comfortable sending out there, and we have folks that are just rock stars. But they're all certified, so they all are your subject matter experts. And maybe you don't even have certified I-10 folks. So then you need to be looking externally, and that's another vendor that you'll look at. How do you get providers in a room and do education? Can you provide CMEs? Do you provide an evaluation through a web-based training that they're already used to? If they're contracted and there's no incentive for them to provide or receive that education, how do you ensure that occurs? Does it go through medical staff? And we're all in the Kansas City metropolitan area. So why, I'll pick on Barbara, why does my doc that goes over to St. Joe have to get the same education that he's going to have to get over at St. Luke's? So I have to do this 6 times because I go to 6 different hospitals. So we're trying to coordinate and make sure that the education is appropriate for the provider, whomever that may be. It could be a coder, it could be a physician, it could be your nurse practitioners, it could be just the nurse providing the assessment. But do not forget about that front end revenue cycle. Who's doing your pre-authorizations? Who's doing your evaluation of scheduling? It's so focused on CPT, and with the movement of medical necessity around ICD-10, and that's one of the last slides. I didn't leave it for last because it was that horrible or that exciting. It just ended up flowing in the agenda. But you know, CMS has come out with all of their LCDs and NCDs for the medical necessity for ICD-10, so it's not going to get lost. And that process still does need to occur. So staffing and resources. This comes from, from an HIM perspective. I think we most readily think around volumes. How many coding staff do we have? How many claims are we going to need to be coding? And everyone's told us you're going to have about a 50% reduction in productivity and efficiency. Okay, well, what are my volumes going to be? What are we planning? Do we see an increase? Well, what did Medicare do just, October 1st? Now we have the 2 midnight rule. So all of my inpatient volume that I'd been planning on looks a little bit different now with this 2 midnight rule. And for those of you that may not be aware of what the 2 midnight rule is basically Medicare giving a benchmark that the provider estimates, I think this patient will be in a hospital bed for 2 midnights or greater. So that qualifies them as inpatient, and that's extremely high level. There's more medical necessity that goes into that, but that pretty much gives you the certification of the rationale of the inpatient, excluding inpatient only, excluding death, excluding transfer. But we also know that in our plan, we based on our inpatient volume of what we have today and where we're moving forward. That looks very different. We are cardiac-centric at St. Luke's. We are neurocentric, and some of that cardiac and neuro-based business is actually going to move more to an observation status. So what that means is we're going to be billing by CPT. That doesn't change a whole lot, but our diagnosis will still change. But that means more volume for the outpatient folks. So know what your volume looks like to really be able to affect your staffing. Contract coding, do you have the contract coders code your I-9 counts while your own staff are coding 10? Do you have your staff clean off 9 and make sure that it looks good and accurate while you have the contract coding staff doing some of the 10 and they get into it? Do you do a mix? It's up to the organization. There's nothing that's right. There's nothing that's wrong. It's up to what works for you. But you need to make sure that they're available. And all of the staffing agencies are going to say, yep, we're going to have contract coders for you. You better have a contract that says that, because you're going to plan that I need 12.5 FTEs for a 3-month period of time, 6-month period of time, whatever your evaluation is and how your strategy that you're going to deploy these folks. And then you reach out. Our coders went and they left and they worked for another organization. We shut down. So did you put all your eggs in one basket? Do you think that you're going to go to one contracting agency and then they're no longer in existence in a year? It is the challenge of planning, so make sure that you have a backup. It's with any strategy plan that you have. But and then what's the rate today? $65, $60 an hour, and then with ICD-10, is it 120? Is it 200? You waited to the 11th hour, now it's $300 an hour. How did you place it into your budget? And then the change with ICD-10, we know that it's going to add some staffing evaluations, but depending on your strategy, our strategy has been that all of our hospital coding staff, regardless if they currently code in inpatient or outpatient, they're going to learn the procedural side of ICD-10. And, we got some grumbling. I code CPT. I don't want to code I-10 PCS. Well, because we are changing EMRs, because we've implemented a CAC, because we've done some things, their volumes may not be as stringent as they are today. And they may have some opportunity to be able to float and to grow as a coder. And so you just need to be able to look at your own staffing models, your volumes, what you think that true patient volume is going to look at, inpatient versus outpatient, and then your consulting help. The other piece around staffing resources, trained all of our coding staff. We trained our providers on how to document more specific. We've implemented queries on the front end and back end to help ask questions and get more specificity. Who's auditing? Who's looking to make sure that you thought that A really was A and that it's not C? Who says that in that procedural approach, yeah, I got my approach wrong, and so the rest of my ICD-10 PCS code is wrong, but if you looked at it as a whole, it looks okay, but that's not at all what happened with the patient, but you can't tell from the documentation. So we have, just make sure that you have a pre-implementation plan, you've got a go-live plan, but your post-go-live plan is probably, I hate to say more, but I feel that it's even more important than your pre-implementation plan, because that's where you're going to identify any gaps that you didn't notice in your pre-implementation plan and go live, and that you can actually assess how well staff are actually performing based on the real documentation that is actually occurring. So how do you do auditing now, and do you have that auditing capacity in the future? The other piece about staffing and resources before I move on to computer-assisted coding. Today's October 2014 time frame seems very far away, and staffing models can change significantly. We know that we need X number of coding staff by October 1st, 2014. And we have that number of coding staff, and we're going to plan for a certain percentage, let's say 30%, to support us during the ICD-10 go live, as well as maybe 6 months after implementation. Well, staffing can change. You get 7 out of 10 new coding staff September 2014. What do? They've never had I-10 training before. Now you've got to start at square one. Again, it's just your plan. It looks great when you are able to start from A to Z and everything's going in line, but that's life. Nothing goes in that perfect line. And so just have an idea of what you would do. Do you not hire if they've not had any I-10 training? That could be a possibility. Do you have them work your I-9 cases and not the contract coding staff? That's a capability. There are lots of solutions, but there is not one solution for every organization and every facility. So computer-assisted coding. Does anybody have implemented a computer-assisted coding? Yeah. Outpatient? Yep. Auto billing or suggested? Okay. So there are lots of different opportunities with computer-assisted coding, and as we have more text-based documentation and metadata from our computer-assisted codings, they're the wave of how we need to continue moving forward. It's when transcription changed to a speech recognition software tool. There are always pitfalls in every technology solution, but you use the technologies for your benefit, for your advantage, and you try to evaluate what is it going to do for you. So we have implemented a CAC on the outpatient side. We're going to wait on the inpatient side when we transition to our next EMR. So here's the scary code pieces where we go from 13,000 to 68,000 diagnostic and 11 to 87,000 for procedural. But really, how many? It's just like a dictionary. There's thousands of millions of words. But how many do everyday processes actually use? So you want to look at your 80-20 rule of what codes are you actually using today that you really need to evaluate and how it's going to impact you. And you can utilize your computer-assisted coding software tool to help hone in, if you're using it in 9, to start teaching the software what might be coming in ICD-10. So it does help professionals, coding professionals. We still need coders to evaluate that chart and make those coding logic decisions. But the CAC is just a tool it's structured text. It's coming through. It's not an image. It could be unstructured from an EHR, depends on what interface you have going to the CAC and what they can accept. And it's using some type of natural language processing or comprehension to take that code logic in the back and say, based on these combination of words and structure of sentence, this is the code or codes that we would have suggested. Not only does it help to make sure from a quality perspective, human eyes may or may not have seen certain words, diagnoses, or procedures, or even in the context, but that also goes into the CAC. It doesn't mean that it's accurate. So you still need that coder to review and evaluate whether it was an accurate code assignment or not. You don't want to move to a CAC if you don't have text documentation. I think most people are moving in that direction if they've not already. But this is where also I go back to those outpatient coders, because your outpatient coding staff could assist with the inpatient coding claims if the computer-assisted coding works really well for you. When we implemented our same-day surgeries, it's been about 10 months ago, we've seen a 60% increase in production. We didn't expect to see that. We expected 30 or 40. And CPT is not going to change. I9 CM will go to I10 CM. So we're going to probably see, we expect about a 19% reduction for those staff. But again, we're going to be able to reallocate some of those resources. So not only can the computer-assisted coding help with evaluating what types of I10 codes would be suggested, not missing words or diagnoses or procedure terminologies within your NL textual documentation, but then it can also provide, depending on the rest of your organizational structure, cues for core measures, cues and work lists for evaluating how many patients did we actually state that they got screening of tobacco cessation or tobacco education. So it doesn't have to just be an I10 tool. It's what we've initialized and started it as, but there are many other software solution technologies that we can utilize it for. It's also going to be our tool for quality review audits. We know that we're going to be limited from a resource and FTE perspective and how much we can ask external consulting firms to audit our information. We know the government does that for us for free. But we would like to make sure that we have additional tools. So we're going to set up rules. Anytime these code combinations come up, don't let it go out the door to be billed. Send it to a reviewer. Make sure that it looks accurate. Those are the types of software solutions that you can use for the computer-assisted coding. But I am an HIM professional. I should probably talk about at least the top 10 issues of what you might want to focus on depending on your provider area. Diabetes. This is a section that goes tremendously from a small amount of codes to a very large mapping. This is not a one-to-one mapping from diabetes. If you have endocrinology, if you have diabetic patient populations, you do not want to be sitting in not otherwise specified code diagnoses. That 9 at the end is kind of our target issue, to not have the 9, which means not otherwise specified for our coding mechanisms. Our injuries, our external injuries, change completely. In our coding world, there are E-codes today. We don't have E-codes in ICD-10. Same thing with V-codes and our history codes. Those go away. Drug underdosing. We never even coded drug underdosing in I-9, but this is a large category actually in I-10. Your infarctions, you need to know, and neurologists and neurosurge providers are very good about commenting clinically what is going on, but that's where your ClinDoc programs need to tie in, because midline shift means a lot, but it means nothing in coding terms. We need brain compressions, we need cerebral edemas, we need specific diagnostic terms. So, look at your patient population, know what types of specificities you're looking at. AMIs, it's no longer 8 weeks, now it's 4. If you've had an AMI within 4 weeks, then you've had a recent acute MI. Neoplasms, that whole chapter just got turned upside down, so I won't go into a whole lot of detail other than your neoplasm and your anemias, your sequencing completely flip-flops than what it is today. And if you've had coding staff who have been coding for 20 years, it is very hard to break those habits. And it's very challenging from a quality perspective between the months of September and November, where you're still cleaning off stuff from your 9 cases and you're moving to 10. Okay, I've got to switch brains. Don't have them do both. Don't have them do 9 and then a case in 10. Be able that they can switch off their brain and think about 9 and then switch on their brain and think about I-10 coding rules. And we've got groupers and we've got technologies and we have edits, but they may lead you down a wrong tree path. Technologies can't do the entire process. They've got to be able to understand their indices and their tabulars. Musculoskeletal conditions, this is more on the PCS side where we need that specificity. Our pregnancy chapter changes quite significantly, and our respiratory events, not so much how we code the hours any longer, but evaluation of some of the settings. And then, just your whole book on the procedural side. It's a very different coding nomenclature. It makes sense. I like it better. It relates very similar to CPT, but it is something that folks have to understand how to read a procedure or an op report and what's going on during that procedure in order for them to be good at I-10 PCS. So there's dual coding. There's dual coding and there's double coding. So dual coding is you're natively coding both 9 and 10 at the same time. And many groupers have a translation tool. So you've coded your 9, you click translation, and you can see all of the possible ICD-10 codes that are available for the more than one to many mapping. And so knee pain, for example. Right now there's an I-9 code for knee pain, and there are 5 different I-10 knee pains. Is it right? Is it left? Is it specified? Is it not specified? Is it medial? Is it lateral? Those are the types of things that we get for the specificity and the granularity in ICD-10. So the thought of dual coding is that someone, while they're coding in ICD-9, they're coding in ICD-10. You can have this performed by different folks, and we're going to talk a little bit about double coding. But dual coding, if you do it in that fashion, perfectly fine, great exercise. The more that the coding staff code in ICD-10, the more comfortable they're going to get with it, the more opportunities they're going to identify for documentation improvement areas. You can start doing queries ahead of the time. It's a great process. We really need to be able to do it. Do we have the staffing? No, you're not going to be able to do it on all the counts. How do you identify which accounts you want to do dual coding on? How many staff per day do you have dual coding? Someone may just be extremely slow still. So how much time are you going to allow to allocate? So do you set the number of accounts? Do you set the number of hours? That's up to you. We've decided to do actually double coding. And what that's going to allow us to do is someone codes in 9. It's going to go through a workflow based on a specific payer that we can actually do testing with, and based on it was a very small percentage of our total population. So every single coder will get an account at some point in time. It will go to a queue for them to code in ICD-10. Same coder may not get that same account, and I'm okay with that, because if I'm a coder and I've coded it in 9 and then I code it in 10, I can't really judge productivity. It's not apples to apples, because I've already read that chart and I know what's going on. So I'm already ahead of the game, and I've already been a little bit, and that's fine. You can still do that during dual coding, but just make sure that you take account for that and not thinking that you're going to be much faster at I-10 than what you anticipated. But once they code a chart in 10, then it's going to route to our auditing staff, and they're going to evaluate the competency of that coder, evaluate the documentation improvement needs, and then we're going to continue to circle that back. That information goes into our internal data analytics so that we can start talking about DRG shifts, financial impacts, which is what we're going to talk about next. So you can do either one, you can do both. But there is a very big difference between dual coding and double coding. It is the most effective method of grabbing data and making sure what your data looks like. Anyone, well, not anyone, but many vendors can take your claims data, take your 835s and 837s and send them through and state, based on what we have, here's spit out from our data mining software solution what we think you're going to look like in 10, and here's your focus areas. And that's great. And that gives you a starting point, and you should know that information, but that doesn't tell you anything about the documentation. Well, that just tells me what that mapped to or what the possibilities were, but now I still need to go back to the chart and see if I needed to go talk with Dr. ABC about his procedural documentation for arthroscopes. So you need to be able to evaluate this information, because we cannot lose the case mix index that we have today. You know, Medicare, it goes directly into my financials, Medicare states that this is going to be budget neutral, financially neutral. Not quite sure for whom, because we've already put a lot of money into getting us prepared, and we have a lot of opportunities for cash issues. So the first piece that I want to make sure that we go over is crosswalks and financial modeling. And if you are a hospital, you have got to know what your DRG shifts are going to be. If you have a very small patient population, so we've done 600 transplants, so 600 out of our millions of claims, that's a very small. But if I have a DRG shift from a 1 to a 2 with my transplant, that's $100,000 difference. No one wants me to make that mistake. DNFB changes. We have, from the entire revenue cycle process, if we got the documentation and we've got it coded and we think it's accurate and it runs through the scrubbers, but the scrubber is not, and the edits are not built for 10 appropriately, and it holds everything, that's going to kill your discharge not final build. So would not be a bad idea if you have an external agency who performs your auditing and evaluating your organization. I'm sure they have already suggested this, and if they have not, you might want to suggest it to them. You need emergency cash flow. I mean, that is really the basis. How much emergency cash flow is going to be dependent on your organization, but you have got to be prepared, not necessarily for you failing, but for the payer failing. Are they ready to accept the information, or they say they are, and then everything comes back as a denial? So you don't have one paid claim. Can you still pay your nursing staff and your coding staff to continue evaluating your patient flow? So we need to be looking at this not just for how does this affect our financial results and outcomes and evaluations, but are we ready for, and you know, maybe it's as bad as Y2K and nothing really happens, and that will be fantastic. but please make sure you have enough in your savings account that you can pay your mortgage. You really need to set your measures. We have an entire benchmark set up, but these are the 3 top ones that everyone really needs to make sure that they have. Your days not billed, as soon, you know it's going to go up, but at what threshold do you throw down the fires and everybody comes into a room and figure out why it's going above that threshold, or went above the threshold and it's going back down? Okay, we feel good. Oh, it's keep going up, then we need to evaluate those processes. Claims delayed. So working with your, everyone calls them different departments, but your payment claims or processing or denial units, and making sure that they know what they're looking at. They're very used to the edits that pop out for the reasons of denials, or their CAS codes, or their remark codes. They need to make sure that they're familiar with the new remark codes, and then the number of claims denied. Hospitals, 72 hours. So you have an ER patient that comes in on 9/28, and you've got an inpatient who comes in on 10/1 and discharges on 10/7. 9/28, that's I-9 codes. 10/7 discharge, that's I-10 codes. What do? You can still build on 10. But you need to be able to evaluate those processes, because you're really combining the charge and the bill. But you're going to run into some of those scenarios that are a little bit messier. If you have rehab and acute care, we have what are called 3-day interrupted stays. And so I go from rehab, I have worsened from a medical condition, I go to an acute care setting, and then I go back to my rehab. The way that rehab pays us is that they want one bill. They don't want those 2 rehab stays as 2 separate bills. First rehab was at the beginning of September 2014. That's I-9 codes and 1 DRG, or there's 2 DRGs for rehab. And for rehab with I-9, our principal diagnosis is a V code. Those go away in 10. How do you combine them? You need to work with your payers to evaluate how do those workflow rules go through your current workflow today, and evaluate where do you have the biggest opportunity. With the billing and financial system, I-10 impacts update support for your groupers. You must have technology, as I mentioned earlier. It doesn't do the end-all be-all, but you want to make sure that your groupers are tested and they're available. Charge masters. What's being held on a hard code, and does that change with I-10? So there are now imaging and fluoroscopy pieces that we have never coded in 9 before. It pulls from the charge master, but there are now 10 codes, and so we're going to switch processes on a certain environment and make sure that we put that into our workflow. Denial management, that's really the area that I think that we're the largest at risk. This is just a picture, and I would like for you all to pull out your magnifying glasses so that you can see it, but we've got all of these different sections from a hospital perspective. You've got your admin and your finance sections, but you have all of these clinical areas, and ICD is going to affect all of the different pieces. And here's your interface section that you have opportunities. So you could have behavioral, you could have psych, you could have all of your transcription services and your rehab. All of the different areas, going back to that very first slide that looks so very simple of just 5 little wheels around the circle hub, this is what you start to see in the detail. So on contracts, my biggest piece that I will give in regards to advice again is make sure you have some cash flow. Because you want to make sure that, if you have contracts and they're set up in I-9, make sure that they're converted to 10, and what does that look at from a rebilling perspective, and what are they going to accept and what are they not. But the biggest piece is that payer may not be able to handle I-10 as their plan thought it was going to. So locate in all of your contracts where you've got I-9, if you have them at all, and make sure that you've got it situated to ICD-10. And then you do need, we talked a little bit about it earlier, but make sure, what about those payers that don't have to be HIPAA compliant and they're not going to accept 10? And how are you going to process those claims? Can your clearinghouse send out both? Do you need, if it's not a one-to-one mapping and you need to have someone manually code that in 9, can't lose our 9 skills. We know that we're going to have denials and rebills and evaluation, but again, making sure that we have a true perspective of how it looks. So here's my pretty denials screen before we close and go off to the panel. But I wanted to make sure that you had a couple of different links because the CMS website can get a little complex if you go out and look at all of the different opportunities. And they, I will have to say, CMS has provided an awful lot of resources out there, from a checklist to a program management implementation. But once you get into it, sometimes it's not exactly what you evaluated in the detail. And the details I want to make sure that we don't forget is around the denials and our LCDs and our local coverage denials and our national coverage denials. And these are 2 links, and it basically takes you out to this spreadsheet. And they've got a tab down here for I-10 diagnoses, they've got their I-10 procedures, and they've got their rule descriptions. So over here on the left-hand side, you've got all of your I-9 codes, and so these are all of my mechanical complications of a defib, defibrillator, and then here are all of my I-10 codes, and you can see 99604 from rows 16 to 27. From rows 16 to 27 and 10, they're all different codes. And so if you have on your back end, or technically your front end scrubber or your editor, to be looking for one simple I-9 diagnosis code, you need to make sure that it has all of the mapping to be able to evaluate these LCDs and NCDs, because as any organization, we want to be sending out clean and accurate claims, and we want to make sure that we're catching this before payers do, and then they evaluate that it's extrapolation, we don't know what we're doing, and then we have folks in even darker suits come in and want to evaluate our workflow and revenue cycle. So again, very high level. It's not the most exciting, fun things to talk about, but we have got to talk about them. And I'm glad to see kind of a mix of folks in the room, because it's going to take an entire organization, no matter which organization you work in, to make this successful. And we can. We do not need to be fearful. It does not need to be in the blind spot. Please do not put it in the blind spot. If there's anything that you do when you go back to your organization today, is just to get a grasp, if you aren't currently already, where we're at and what your competing projects are, because that's my biggest challenge along with our clearinghouse. So with that, I'll conclude, and then I think we'll go into the panel.